This is Brian Wormers recording a lecture on Chapter 45, which is Genitourinary Dysfunction in Pediatric Patients. Looking at some of our objectives, we're going to cover UTIs in infants and children. We're going to talk about nephrotic syndrome. We'll also talk about post-streptococcal glomerular nephritis. We'll also talk about pathophysiology and management of a child with hemolytic uremic syndrome. We'll also look at acute and chronic renal failure, and then list some types of renal dialysis. So, jumping in, we're going to talk about some of the basic diagnostic tests that you can do. So, within this, you're going to see that there's lots of different ways to assess the genitourinary system. We can look at observation. Back in the olden times, that's what we primarily did. Was it clear? Was it yellow? Was it cloudy? Did it have a funny smell to it? The ancient Greeks and Romans used to taste it. And if it tasted sweet, then they knew it was diabetes mellitus instead of diabetes insipidus. So there's lots of different ways. I'm very grateful that we're not doing some of those anymore, but there's lots of ways to glean it just on observation. History and physical are a few more ways that, of course, are ways to get a good understanding of your patient. So when you are doing this, make sure that you include these things. You guys have done H&Ps for a while now. So, in addition to a good old H&P, we do have lots of different diagnostics we can do. We can do the UAUC, we can do looking at the urine underneath microscopes, we can look at complementary factors, we can look at doing urine CTs, MRIs, ultrasounds. There's just a wide variety of different things. We can do VCUGs. So there's lots of different things that we can talk about with diagnostics. So please know all those different types of diagnostic tests that we can do and how they're going to relate. So UTIs are one of the most common infections of childhood. It occurs up to 7% of all children, and it tends to be more common in females than guys. So lots of different types and lots of different ways to classify it. You can have it recurrently, so happening repeatedly. You can have it persistent, so even though you've given antibiotics, it's not clearing. Febrile, which can be, oftentimes it's a pyelonephritis. It's gone up the urinary tract high enough where it's causing complications in the kidney. And it can even cross into the blood barrier, causing urosepsis. So some of their big risk factors, so uncircumcised males less than 3 months of age are at a higher risk, as well as females because of their shorter urethra. I think that you guys are all aware of that. One of the biggest things is urinary stasis. This means that the urine's not moving. So people aren't drinking enough, number one, to cause filtration and a pressure to void. The other thing is that people are not voiding enough. I've talked to a urologist one time and he said that nurses were his best friend as a patient, because our role as nursing, we don't drink enough and we don't go to the bathroom near enough, and that leads into some problems later on in life. But just remember that urostasis is one of the biggest key factors for this. Also, know about reflux. We'll talk about that here in a little bit. And then sexually active females. And that's been theoried for a couple of different things, of course, because of the penetration, but also related to any foams or gels or accessories that are being used. So I do want you to be aware of that the most common organism for UTIs is E. coli. 80% of the UTIs are actually an E. coli base. But be aware that there are some other ones. So if you want to know kind of a fun pathognomonic or mnemonic for it, it's SEEKS PP, and it covers it right here. So what are the signs and symptoms in kids about a UTI? So lots of things are related to eating. They're just not feeling hungry. They're going to be nauseous. They could puke. They're not going to gain weight. They're just going to be fussy. They're going to run a fever. Foul-smelling urine, lots of urgency, lots of frequency and voiding. So those are some of your common findings of that. Treatment, of course, whatever's causing this, you want to eradicate. So if it's E. coli, which 80% are, you give some antibiotics, and hopefully that will help. You can push it with fluids to try and clear some of that urostasis out and make sure that they're hydrated well. You can give some cranberry juice. It's got to be the real stuff. It's not just the flavoring of cranberry, but real cranberry juice is acidic. And that acidic environment can make it so that the infection doesn't want to stay there, and it helps. Plus, if you're drinking lots of cranberry juice, it's increasing fluids, ending that urostasis, and helping that way. So decrease some of those risk factors that we talked about above, prevent the spread of infections. So, good hand washing, of course, with this, and then trying to catch things early so you're preserving renal function. We don't want this to go on and escalate up the UTI tract and causing nephritis and complications that way. So reflux is a fairly common anatomic problem with this. It's when that urine is actually flowing backwards. So instead of going up, instead of going down into the bladder from the kidneys, ureters, bladder, and urethra, it's kind of going up from the bladder. And that causes problems, especially with infection and having it bring back up into the kidneys, and pyelonephritis, of course. So we can see, this is a good little blog spot that you guys should check out. But you're going to see on those images that you can the way that urine is going back up with a VCUG. So avoiding cystourethrogram, you're injecting dye into the bladder to see what happens with it. And so on some of these images, you're seeing that it's going up the ureters, even up and into the kidneys. And of course, that's a bad thing. If this is happening, surgery may be done to repair this. Sometimes if it's not bad, they will try to let the kids grow up and see if they quote-unquote outgrow it. But the other thing that they can do is a procedure called a deflux. And a deflux procedure means that they're injecting a small amount of like a silicone type of a thing, trying to make a narrowing on the ureters and trying to prevent that urine from flowing back from the bladder into the kidneys. So next we're going to talk about nephrotic syndrome. And this is a disorder that's caused by increased glomerular permeability to plasma proteins. So basically, we start peeing out these plasma proteins. So when we do that, then the protein from our blood tries to compensate and balance out a little bit, so we lose more from that. And as a result, the protein is what's really keeping a lot of the fluid in our body to stay where it's at. And so in those shifting proteins, of course, we're going to shift the urine or the fluids around with that. And so with that, we're causing decreased and problems with our osmotic pressure. And this loss of protein is going to cause hypotonicity in that vascular space, causing those fluids to shift out. And what we see is a lot of edema. And it's really quite sudden. It's quite impressive. It can be so sudden and such severe shifts that we actually see hypovolemia with it. So what do we do for this? So our management is basically corticosteroids. Oftentimes it's prednisone, but sometimes people use different things. And then you can use immunosuppressant therapy. But we're also going to do some things that are not pharmacobalanced with that. We're going to watch the fluid, we're going to watch the salt, and we're going to try and maintain some stasis with that fluid. So also want to try and prevent infection, especially in those ureters and those kidneys. And then oftentimes we're going to watch them very closely. We're going to see how they're doing for their fluid status. And that's going to be doing things such as weights or twice a day weights. We're going to be looking at measurements. We can see, that their clothes are fitting tightly and that their shoes aren't wanting to fit or things like that. But oftentimes what we'll do is we'll actually do a direct measurement of abdominal girth or other things like that, just to track things to see how much fluid that they've got on board. So in acute glomerular nephritis, this is the most common thing associated with infection, and this often happens with post-streptococcal glomerular nephritis. And so we've talked about how dangerous strep is before. It's not that we treat it because of the sore throat, we treat it because it goes into the heart valves, and we treat it because it goes into the kidneys. This also can be a sign of a systemic disorder such as lupus, but it's more common to have it as post-strep in children. So what we're really trying to think about is why this happens, and we think that you get some antibodies from a previous upper respiratory infection or something along those lines. The antigens and antibodies kind of clump together and they clog up those tubules within the kidney, and that causes problems with that. So I do expect you guys to know the difference between acute glomerular nephritis and nephrotic syndrome, and these will help with that a little bit. So one thing that these patients can have is tea-colored urine. And so something I want you to realize is that it's the breaking down of the hemoglobin that's giving it this color. So it's actually the blood in the urine that's giving it a dark color. So treatment of this, of course, is treating any resistant strep, watching for hypertension. Anytime we're talking about the kidneys, we really have to watch about the adrenals, and when that happens, we have to watch for blood pressure issues. We're going to monitor edema, we're going to look for weights, we're going to talk about I's and O's, and we're going to talk about watching their diets a little bit. Oftentimes we eat way too much salt in our diet. I'm guilty of this as well, but just be aware that we need to monitor that, make sure that we're on track. So HUS is an interesting disease process. It happens to littler kids, generally speaking, and it can happen from a lot of different things. But basically what we're seeing is you get a triad here. You get anemia, you get thrombocytopenia, and you can lead into some renal failure. Hopefully that this is a short-term type of a renal failure, but it can be lifelong. Oftentimes, the one that we are talking about the most is this E. coli 0157 H7 serotype. We get it from petting zoos. We get it from undercooked meat. Can get it from things that are hard to wash for your vegetables, such as sprouts, lettuce, spinach, those type of things. The one thing that makes this kind of interesting is that we do not want to give antibiotics for these patients. So oftentimes they have, significant diarrhea because of these things. But if you give the antibiotics, you lyse all these cells all at once and release all those endotoxins, and it's really hard on the kidneys at that point in time. If that happens, they probably will go into a renal failure, and dialysis will be recommended. So how do we get the triad, so to speak? So the anemia is caused because the RBCs get damaged. And as they get damaged, they go through and the spleen will then subsequently remove them. So that's how you're getting your anemia. Thrombocytopenia will work in the same way, as your platelets are getting affected with this, as well as a result from that anemia, you're getting platelet aggregation, clumping. It's causing damage to those vessels, and that's what's leading to that. When you get those clumping and such like that, that's happening in the kidney, that's where you're getting your renal failure from. So that's how you get your big triad here. So on your physical assessment, really kind of think about what your patient's going to look like. Oftentimes they're going to have some bruising and petechia because of the thrombocytopenia. They're going to be jaundiced because of the cell destruction. Their spleen is going to be big because it's processing all those cells. And what do you think on their urine output? Oftentimes what they have is they have a lack of urine output. So most of these kids will do well, but there is a subset of them that will have some residual renal impairment. I know 10 to 50% is a wide margin. I've heard about 25% will need a dialysis, and 25% of those kids will actually need some longer term dialysis. Wilms tumor. Wilms tumor, just breaking it down pretty short and sweet on this one. It's a tumor growing on the kidney. It's common in childhood. Oftentimes it's unilateral. But the one thing that you've got to take away from this is do not palpate that. So we talked about the adrenals earlier in this lecture. If you push on this tumor, it can have an adrenal secreting component to this tumor, and therefore you're going to jack the blood pressure up on patients and cause a lot of hypertension. So the other thing is this tumor can actually break off, and then if it breaks off, it can seed into other areas and make treatment of this much more difficult. if your patient has been diagnosed with a Wilms tumor, it's tempting that you want to palpate and feel on it, but please do not. It's something that will be very bad for your patient. Overall, these patients do very well, and their survival rates are above 90%. So acute renal failure, so we talked about this in the adult world in med-surg, and it's very similar in kids. So there's lots of different things that can go on that causes acute renal failure. Probably dehydration and hypovolemia is the biggest thing. They get dehydrated from cold or infections or severe diarrhea, and then that hypovolemia really affects your kidneys. You can talk about lots of other things though, such as glomerulonephritis, HUS that we just talked about. We can talk about polycystic kidney diseases. We can talk about reflux. We can talk about chronic UTIs. So there's lots of different things that can cause renal failure. So one thing I want you to remember and really think about though is that there's three different things for renal failure. Is it pre-renal, is it intrarenal, or is it post-renal? And so basically we're looking at what the complication is. So if it's pre-renal, so that means before it gets to the kidneys and you're having complications there, oftentimes that's a blood flow type of a reaction where you're just hypovolemic. Intrarenal, so you can talk about like within the kidney, so polycystic kidney disease would be one of those things. Or you can talk about post-renal. So if you're talking about kinks here on the ureters, or problems with the bladder, or in the urethra, that's where you're having some of those other post-renal things. So think about it that it's, pre-renal is before the kidney, intrarenal, of course, within the kidney, and then post-renal is after. So with renal failure, it's often reversible, and what we often do is lots of hydration, getting good perfusion to the kidneys, and managing that output, watching them very closely with that. So be careful though that once you start rehydrating, they can go through a high output phase. The kidney is still injured at this point in time, and so it's not concentrating fluid appropriately, but you're going to see lots of dumping then as it starts healing. So lots of different complications with ARF. Hyperkalemia is one of the biggest things. We're not peeing off that potassium. It's building up within our bodies. And this, of course, can cause problems with cardiac arrhythmias as well as some acidosis. So dialysis can remove that potassium. Otherwise, we can give binders such as Caxolate and then remove some of that excess potassium. Hypertension. So if we're not getting good perfusion and we're not getting good flow, of course, we're going to increase our squeeze on our adrenals and try to get better perfusion, and that can lead into hypertension. So fluid resuscitation is a must for this, and then maybe even we can talk about some medications to limit the hypertension. Anemia, depending on what's going on and what's causing this renal failure, it could be a couple of different things. We can also talk about how erythropoietin comes from the kidney. So if you've got damaged kidneys, you're going to have potentially a damaged outflow of erythropoietin, which makes your red cells, and that can lead to an anemia, especially like in a chronic kidney situation. With electrolyte disturbances, of course, you can get seizures. You can also talk about hypervolemia, where you've got too much fluid on board and you're not excreting any. And then, of course, with that, we can talk about cardiac failure related to the increased volumes or the electrolyte shifts. And then that increased volume, of course, can cause pulmonary edema as well. So what are some of the causes? So we talked about acute renal, but if we can't get that corrected, then that can lead into chronic renal failure. And so some of the major things are, just like what we see for the acute stuff. It's just we can't treat it. We weren't effective in treating it, and they progress and they have this for a longer period of time. So same things that cause would be congenital renal malformations, of course, or UTI, urinary tract malformations. We can talk about reflux. We can talk about UTIs chronically happening. It's usually not a one-time thing, but it's chronic things that are happening and multiple UTIs. We can talk about chronic pyelonephritis or glomerular nephritis if we get that infection up there and we can't clear it adequately. So all these things that you've talked about in the acute form, if they just progress and we can't treated appropriately, it goes on to chronic renal failure. So what are we going to see? We're going to see patients that are, turning a little bit jaundiced. They're not clearing urine out. They could get the uremic frost on them again, like we talked about in the adult patients. So they retain those waste products. Probably the most concerning is potassium. But then, of course, we're going to talk about BUN and creatinine with those labs. They have to monitor the urine very closely to see what they're making. And with that, we want to see what their water and their retention, sodium retention is doing. So we talked about hyper-K before. We talked about acidosis because of metabolic disturbances. We talked about calcium and having that build up, as well as phosphorus. So with chronic kidney disease, if the kidneys are diseased bad enough, just like in the other things that we talked about, this can lead into a problem with erythropoietin, and this can cause anemia. And then, of course, it can affect your growth hormones too. So management and diet and chronic renal failure. So end-stage renal disease in kids look, very similar to adults. So we can talk about that kind of stuff. We can talk about vascular access for dialysis. We'll talk about that here in a little bit. But with this, we're going to have to talk about dietary issues, and this is hard in kids. When they want to be eating just like everybody else, they want the chicken nuggets, they want the fries, they want the salt, they want the things that all of their friends are eating. But we have to realize that this is going to be really difficult in kids. So last we can talk about treatment of this. So we can talk about dialysis. So there's two major types of dialysis: peritoneal. So you infuse into the peritoneum of a hyperosmotic fluid, and that fluid is used to pull off some of the additional fluid and waste products. So you basically drain fluid into their abdomen, let it sit for a little bit, and then you drain it out. And hopefully when you drain it out, it's pulling the additional fluids as well as the waste products with it. It's not super high tech. There's lots of cool things out there, such as autocyclers that people can connect themselves up to at night. And they can be managed at home in many cases. I've known some people that really like peritoneal dialysis because they could do it during the night and then they could go to work the next day. One thing we do have to watch for this, of course, is going to be infection. Anytime we're running into the body, we got to be very careful about how we hook the tubing up. We got to look at that effluent that we're using, or the fluid that's going in, and what that looks like, and the effluent that's coming out, and make sure that's clear. Otherwise, we really have to be concerned about peritoneal peritonitis, and that's a major concern. A good trick that I've learned, because my mom was on this for a while, was if you're curious about that fluid at all, place a piece of white paper behind it. If there's any kind of distorted color or something like that, that white sheet of paper can actually help you see some of the cloudiness that would occur with it. The other thing we could do would be a hemodialysis. I think most of you guys have seen this before, and this really takes kind of a special hookup. You need vascular access to do this, and a special line. This could either be a graft in their arm with an AV graft, or otherwise this can be different catheters and stuff like that you're running on. So with this, of course, this is going to be usually 3 times a week for 4 hours at a time. And so it really is a time suck, but it's something that's necessary. Without it, these patients will die. So this can cause some rapid correction of fluid and electrolyte, and that in and of itself can cause some complications because you cause fluid shifts, and you can cause some cramping, and you can cause some other issues like that. In a very acute setting, if patients are very sick and they're unable to tolerate this as a 4 to 6 hour run, you can do hemodialysis as a continuous run or over a longer period of time, say 18 hours or so. But that's usually for inpatients only. So the last way to treat it would be transplant. So lots of different ways to get a kidney. So you can either be from a living donor, such as a family member, or people are recruiting nowadays. Otherwise, you can have a cadaver donor. So somebody that was oftentimes in a motor vehicle accident, or somebody that was declared brain dead is a good candidate for this. So basically you're taking the kidney and using that transplant kidney in, and hopefully that will take within that person's body. So long-term goal, of course, is survival of that grafted tissue. They're on many different medications to try and promote this and prevent the body from rejecting it. There's lots of different types of rejection on this. I mean, it could be hyperacute, so you're seeing changes while they're in the surgical suite, and before they even close up, you're seeing that the body's rejecting it. Acute, I think, is the stage within 30 days, and then you get more chronic things. So, but just be aware of that role immunosuppressant therapy has on this. We're really trying to prevent the body from rejecting it, but this medication can be hard on the patient. It doesn't always make them feel good and can cause some complications that way, so compliance is a little bit iffy. And then the hours that they have to do this, oftentimes it's a lot of meds throughout the day. So, well, this concludes the presentation on pediatric genitourinary dysfunction. If you have any questions on this, please contact me.